Good evening. I'm Dr. Nandini, Associate Professor from the Department of Anesthesiology and Critical Care from Saptagiri Institute of Medical Sciences and Research Center. At the outset, I'd like to thank Dr. Balabhaskar sir, Dr. Jyotsna ma'am, for giving me an opportunity to talk in this forum. My topic today would be on blood and blood products in anesthesia. I'll be covering this topic under the following headings, namely constituents of blood and hemopoiesis, functions of the blood, and I'll be briefing you all about blood groups, transfusion, blood products, and conservation strategies. So blood is mainly the fluid constituent of cardiovascular system. It has a plasma and a cellular component. The plasma component comprises of 55% of the total blood volume, out of which 91% is water, 7% is blood proteins like fibrinogen and albumin, 2% are nutrients, hormones, and electrolytes. Cellular components are 45% of the total blood volume, and these are white blood cells, platelets, and red blood cells. So the sites of hemopoiesis varies according to the age. In the fetal age group, initially it is at the yolk sac, following which in 2 to 7 months of the fetal age, it is about liver and it's in the liver and spleen. Then it is in the bone marrow. In adults, it is at the vertebrae, the ribs, sternum, sacrum, and the pelvis. So there are certain pluripotent precursor cells, namely the erythroid, granulocytic, monocytic, and megakaryocytic cells, which are involved in maturation of the cells, and they form the end products, which are the mature cells, which are the erythrocytes, the neutrophils, eosinophils, basophils, monocytes, and the platelets. So speaking a bit about erythropoiesis, when it is controlled by the hormone erythropoietin, which is a glycoprotein hormone synthesized in the kidney mainly, but about 10 to 15% of it is also synthesized in the liver. When there is any hypoxia, there is an increase in the hypoxia-inducible factor, which in turn increases the production of erythropoietin from kidney. This increases the erythropoiesis. And once erythropoiesis has occurred and mature RBCs have released, the hypoxia-inducible factor reduces, and it has a feedback on the erythropoietin and reduces that in return. As you can see here, the red blood cells has a biconcave spherical disc shape, which is about 2.5 to 7.5 microns in diameter. The shape is such that one, it increases the surface area for the functions of the RBCs. It also helps the RBCs in traversing narrow capillaries and helps out in wear and tear. So the RBCs have a lifespan of about 120 days. They are mainly comprised of hemoglobin, which is a protein. It's a tetramer which has 4 subunits. Each of the polypeptide chain it has a polypeptide chain, which is the globin, which is attached to the heme group. The heme group has a central ion atom, which is held in a ring structure called the porphyrin. Depending upon the globin chains, they can be of different types. So 98% of the adult hemoglobin belongs to HbA1 variety, where the globin chains are 2 alpha and 2 beta. 2% of adult hemoglobin is HbA2, which is 2 alpha and 2 delta. And fetal hemoglobin is 2 alpha and 2 gamma. Fetal hemoglobin converts to adult hemoglobin by 6 months of age group. So the main function of hemoglobin is that it carries almost 98.5% of the oxygen combined as oxyhemoglobin and helps to increase the oxygen carrying capacity. Once the RBCs are destroyed by the phagocytes or macrophages in the spleen, there is release of hemoglobin and it differentiates into heme, globin, and porphyrin. The iron group gets reabsorbed and reused, and they are stored in muscles and liver, and they are reused whenever there is necessity for the utilization of iron for production of RBCs. Similarly, globin goes into a protein pool and it's again stored and reused, whereas porphyrin is excreted as biliverdin and bilirubin. So the main functions of blood would include hemostatic function, homeostatic function, and immune functions. Talking about their homeostatic function, they are involved in the transport of oxygen and carbon dioxide, transport of nutrients and waste products, and buffering and in helping out in acid-base balance. They also have an immune function, and they are involved in hemostasis. Talking about the oxygen transport, oxygen binds to the ferrous atom. One molecule of hemoglobin binds to 4 molecules of oxygen. This there is a characteristic sigmoid shape of the oxygen hemoglobin dissociation curve, which talks about the percentage of the oxygen saturation of hemoglobin against the partial pressure of oxygen. So the sigmoid shape occurs because of the covalent property of binding of oxygen to hemoglobin. As one molecule of oxygen binds to hemoglobin, it causes a change in the heme moiety, which results in increase in affinity for the further molecules of oxygen to be bound, and this results in formation of the sigmoid shape. So there are certain factors by which the oxygen curve can be shifted towards the right and it can be shifted towards the left. So when we talk about the curve getting shifted towards the right, that means there is more offloading of oxygen, which is happening. This can occur in certain hypoxic conditions, acidemia, in cases of high temperature, when there is increase in carbon dioxide, increase in 2,3-diphosphoglycerate. The shift to the left occurs when there is alkalemia, or if there is low temperature, or a decrease in carbon dioxide, or decrease in 2,3-DPG. So the oxygen content can be calculated by calculating the oxygen which is bound to hemoglobin and oxygen which is dissolved, which is just 1.5%. So this formula is hemoglobin into 1.34 into saturation of oxygen plus partial pressure of arterial oxygen into 0.0225. As we know, blood is also involved in carbon dioxide transport. Carbon dioxide is mainly transported 90% in the form of bicarbonates, 5% which is dissolved, and 5% is carbamino compounds. Blood also has a role which plays as a buffer. As a buffering system, it minimizes the changes which occur in pH. Mostly, it is the intracellular proteins and phosphates which are involved in buffering system. However, hemoglobin is involved in 8% of the total body buffering capacity as well. And deoxyhemoglobin is a better buffer than the oxyhemoglobin. When we talk about hemostasis, when there is any vascular injury, there is initially a vasoconstriction which occurs, which reduces the blood flow. Apart from this, there is release of collagen, which causes platelet activation. And along with von Willebrand factor and fibrinogen, there is a formation of platelet plug. There is also release of tissue factor, which causes the coagulation cascade and formation of thrombin, and then which in turn activates fibrinogen into fibrin. Along with these hemostatic mechanisms, there is also an anti-coagulation or anti-thrombotic control mechanisms which are in place, which help to break down the blood clot and cause fibrinolysis and clot degradation. We come across blood transfusion quite commonly in our practice. It's quite interesting to note that it was as early as in 1666 that Richard Lower first transfused blood in animals. But it was only in 1900s that blood groups was discovered by Karl Landsteiner. Some of the most common indications where we are using blood transfusion are in cases of anemia, in hematological disorders, various surgical procedures such as orthopedic surgeries and cardiothoracic surgeries, vascular surgeries, urological procedures, and GI bleeds. So prior to any blood transfusion, it's essential for us to know about the blood group and the cross-matching. Blood group is mainly determined by the ABO system. It is genetically determined with the presence of or absence of antigens A and B. So if we say that the person has blood group A, that means they have A antigen and anti-B antibodies in the plasma. When we say they have B blood group, that means the antigen which is present is B and anti-A antibodies are present in the plasma. AB group has both A and B antigens and no antibodies in the plasma, so they can receive any blood. There is no antibodies in their blood system. So group O, however, have no antigens in the red blood cells, so they are universal donors and they have both anti-A and anti-B antibodies. They're also determined by the rhesus blood group, and we say they are rhesus positive or negative based on the presence or the absence of the D antigen. Cross-matching is done to test the compatibility between the donor and the recipient blood before the transfusion occurs. Compatibility is determined by the ABO, the rhesus, and the minor systems. It can be done electronically with the help of a computer analysis or serologically where the RBC from the donor is mixed with the serum of the recipient. So when the RBC from the donor is mixed with the serum of the recipient, if there is an agglutination, that means it's a positive test, which means to say that there is an antigen-antibody reaction, so the blood is incompatible for transfusion. On the other hand, if there is no agglutination, That means there is no antibody-antigen reaction which is occurring, so the blood can be transfused. This whole process takes about 30 to 60 minutes. So we have to keep it in mind, especially when we are asking for any blood or blood products in an emergency situation, that this much time will go by the time we receive the product that we are looking for. So when we talk about donation and separation of the blood products into different components, we need a donor who has to be tested, who needs to undergo a thorough physical general checkup. The person has to be tested for hemoglobin and hematocrit levels to rule out the presence of anemia, and also certain tests for bloodborne infections such as HIV, HBsAg, HCV, syphilis, malaria, CMV. And after this, when the donor donates the blood, the whole blood is obtained, which can be centrifuged and filtered to remove leukocytes, and various blood components can be separated out. So we get mainly the packed red blood cells. Then we get platelet-rich plasma. From the platelet-rich plasma, we get plasma from which we get, after freezing, we get fresh frozen plasma, or we get cryoprecipitate. And we also, then it can also be pooled platelets can be obtained from the platelet-rich plasma as well. The other plasma derivatives include albumins, immunoglobulins, and other specific coagulation factors. So once the blood is obtained, it needs to be stored. And for short-term storage, refrigeration and addition of preservatives are used. Standard temperature of storage is usually 1 to 6 degrees Celsius. Citrate is used as an anticoagulant. Phosphate is used as a buffer. Dextrose is used as a red cell energy source. And adenine is used to resynthesize the ATP. Cryopreservation, where the red cells are frozen up to almost 10 years, can also be done with the help of glycerol, which is also called the antifreeze. Talking about the individual components, whole blood is very rarely used nowadays. We use citrate, phosphate, dextrose, adenine as the anticoagulant preservative here. It's stored at 1 to 6 degrees Celsius with a shelf life of 21 to 35 days. The advantages are it's coagulation factor rich, and it's more metabolically active when it's fresh. And if there is no other options available, it can still be considered for transfusion. However, as I mentioned earlier, it's very rarely used because we have individual components that can be replaced. So packed red blood cells are prepared by removing 150 to 200 ml of the citrated plasma from the whole blood. They have a shelf life of about 42 days, and they are transfused at a rate of 10 to 15 ml per kg. 1 unit of PRBC increases the hematocrit by 3%, hemoglobin by 1 gram per deciliter. Beg your pardon. The microaggregate free blood can also be obtained, which prevents reactions to leukocyte and platelet antigens. We also have irradiated red cells, which destroys the lymphocytes, and leukocyte-depleted cells, which reduces the risk of infections and febrile reactions. Indications for transfusion of PRBCs can be hemorrhage, bleeding, to treat anemia. Some of the reasons for which we use transfusion of PRBCs. Then comes granulocytes, which are collected by apheresis. They are stored for 24 hours. They need to be cross-matched and irradiated to remove the lymphocytes. They are indicated for use in life-threatening infections in neutrophilic cancer patients unresponsive to antibiotics, and when absolute granulocyte count is less than 500 cells per millimeter cube. There is no specific dose for this, but some of the common articles mention that it can be transfused at a dose of 1.5 to 10 to the power of 8 granulocytes per kg. Platelets can be either pooled platelets or RDPs or apheresis, which is single donor platelets. Pooled platelets are 1 unit of platelets were produced from a unit of whole blood centrifugation. 4 to 6 of these units are pooled together in a single pack, and 1 unit can increase the count by 7,000 to 10,000. Single donor platelets are collected from a single donor, and as the name suggests, in 1 SDP is equivalent to 4 to 6 units of RDPs. And 1 unit increases the platelet count by 30,000 to 60,000. They are stored on an agitator at 22 degrees Celsius, and it lasts for about 3 to 5 days. It does not need cross-matching. However, ABO compatibility is preferred. It has a special plastic bag which allows for gas exchange and preserves the platelet function as well. It's indicated for use in platelet dysfunctions, surgical patients with bleeding where platelet counts are less than 50,000. However, it's rarely used in cases of heparin-induced thrombocytopenia, idiopathic thrombocytopenic purpura, and thrombotic thrombocytopenic purpura. Fresh frozen plasma is collected as a supernatant after centrifuging a donation. It's frozen to within 8 hours to minus 20 degrees Celsius and maintains the activity of factor 5 and 7, which are the labile clotting factors. So once called for, it has to be thawed and used immediately or stored at 4 degrees Celsius for 24 hours. It has a shelf life of up to 1 year when stored at minus 30 degrees Celsius. It contains all the coagulation factors, albumin, and also plasma cholinesterase, and can be used in deficiency of multiple coagulation factors, massive hemorrhage, DIC, liver disease, and reversal of warfarin. Its dose used is 10 to 15 ml per kg. Specifically for warfarin reversal, it can be used at 5 to 8 ml per kg. Cryoprecipitates are prepared as cold insoluble precipitate by thawing the fresh frozen plasma at 4 degrees Celsius. 1 unit of whole blood yields about 15 ml of cryoprecipitate, and 1 pack gives about 150 to 300 milligrams of fibrinogen and 70 international units of factor 8. Contents are factor 8, 13, von Willebrand factor, fibrinogen, and fibronectin. The dose again is about 10 to 15 ml per kg. However, it can also be given depending upon the levels of the fibrinogen present in the blood. It has a shelf life of 1 year frozen, and complete infusion needs to be done within 6 hours of thawing. Again, it does not need to be group specific. However, ABO compatibility is preferred. It's indicated in the use of hemophilia A, fibrinogen deficiency, DIC, and von Willebrand disease. We can also get coagulation factor concentrates, which are specific factors like recombinant factor 8, 10, or vitamin K dependent factors, which is nothing but the prothrombin complex concentrate, which can be used to replace those specific coagulation factor deficiencies. And lastly, we have plasma derivatives such as human albumin solution, which are present as 5 and 25% solutions and used to restore circulating blood volume. And immunoglobulins, which are obtained from pooled human plasma, which are used in cases of antibody deficiency disorders and autoimmune diseases. So depending on the number of days of storage, there are certain changes which can occur in the stored blood products. The percentage of the viable cells 24 hours post-transfusion goes on decreasing as the days of the storage increases. It becomes more and more acidic as the pH decreases. The 2,3-DPG values also decreases as the days of storage increase, and the P50 levels also decrease. So basically the oxygen affinity goes on decreasing. Plasma sodium decreases, and however, the plasma potassium values increases and can lead to hyperkalemia, especially when we are using very old stored blood, because there is easy lysis of the red cells, which leads to hyperkalemia or potassium going out of the red cells. So we are aware that there are a lot of complications which are related to blood transfusion, like certain immune-mediated reactions can occur, which are allergic, anaphylactic reactions, transfusion-associated lung injury, graft versus host disease. We can also have non-immune-mediated infectious diseases or non-infectious diseases like coagulopathies, circulatory overload, hypothermia, thrombophlebitis, to name a few. So there are recent thought processes wherein we are using a restrictive strategy of trying to preserve the blood. Or rather, we are not allowing for blood transfusion to occur, and certain blood conservation strategies are being used. So this needs to be done in a very planned and prepared manner, and a multimodal approach is necessary. First of all, the patient needs to be identified, and the patient who is undergoing the surgery, we need to know the type of surgery, if it is, or how much is the anticipated blood loss that is to be expected. So based on all these, we can use certain preoperative, intraoperative, as well as postoperative methods to conserve blood. We also need to remember that in certain sets of patients, like for example, Jehovah's Witnesses, who are against transfusion of any human products, this can be the only strategy available for us to conserve blood. Preoperatively, if the patient has anemia, treat it. It can be done with oral or parenteral iron therapy, along with even erythropoietic stimulating factors. And autologous donation can be initiated. Intraoperatively, we can do acute normovolemic hemodilution, wherein with the hemodilution, the amount of blood lost or the hematocrit lost is reduced. Antifibrinolytic agents can be used to reduce the bleeding intraoperatively. And cell salvage techniques where anticipated blood loss is expected can be utilized, where the blood which is lost in the surgery is treated and it is transfused back to the patient itself. Positioning of the patient intraoperatively, especially when the surgical site is above the level of the heart, it does reduce the blood loss. Then surgical approaches also, cautious surgical approaches such as using tourniquet or trying to use diathermy or ligating the bleeding vessel as early as possible are some techniques that can be used. Hypothermia has to be prevented as it can cause an alteration in the enzymes which are needed for coagulation cascade. This can in turn cause increase in bleeding. And these are some of the methods which can be used intraoperatively. Post-operatively, we need to have a high degree of suspicion for any kind of bleeding which is happening, and try to use point of care testing when available to identify what exactly is missing or what exactly is being lost, so that we can replace only. If we have to do transfusion, let us only transfuse that particular product or component of blood which is reduced. And we also have to try to maintain normothermia as much as possible even in the post-operative stage. Cell salvage can be initiated even post-operatively if there is a lot of bleeding which is happening in the drains. Restart any parenteral iron therapy if it's possible, and try to use pressure dressings wherever possible to prevent blood loss from the bleeding site as well. So I'd like to conclude my talk by telling that we are using blood and blood products quite commonly in our practice every day. We need to understand what are the different blood products that we have and what are the indications and complications, and how we can improve the patient safety and provide effective care for the patients. Thank you. These are some of my references.